Specific question that I need to address is the value of PABA by comparison with PLGF in first trimester screening for Downs and preeclampsia. Are they both equally useful? Do they have an additive value? Is one of them useful for one condition and the other for the other? This is the question. I am very, very happy to be joining such an impressive meeting with so many friends from Poland and Romania and Bulgaria. The story for me began 30 years ago. These are the images published in the British Medical Journal in 1992 that raised the possibility that the baby on the right has a big nuchal translucency and the baby on the left has a normal nuchal translucency. And there was the beginning of a very long period to demonstrate an association between the measurement of nuchal translucency and chromosomal abnormalities. Subsequently, at the end of that decade, we demonstrated that the measurement of free beta HCG and PABA in the first trimester could be combined with nuchal translucency to increase the detection rate for Downs and other chromosomal abnormalities. And then something different happened. We found that in babies that had high nuchal and the karyotype was normal, there was increased risk of many genetic syndromes and defects, such as cardiac defects. At the same time, in a similar way, we found that if the PABA was low and the karyotype was normal, there was an increased risk for miscarriage, stillbirth, fetal growth restriction, and preeclampsia. So somehow a story that began with these horrible-looking images evolved into a major screening strategy, both for chromosomal abnormalities and pregnancy complications. 1992, 30 years ago. Let me address the question of screening for trisomy 21. And this is the evolution from that original set of images with improving ultrasound technology and biochemistry that by 1999, we had suggested that you can combine age, nuchal, increased free beta HCG, and reduced PABA, so that now you had the best at the time method of identifying about 90% of the babies with Downs and other chromosomal abnormalities. So this is the combined test. Of course, we also suggested in subsequent publications that the nasal bone is reduced, that you have abnormal flow in the ductus venosus and so on. But these additional markers are confined to some super specialist centers. Now, something that I want to emphasize, by comparison with the first images that we saw, this image is the type of images that we expect now and we have been expecting for the last 10, 15, 20 years. And that was a technological advance that was allowing us to diagnose more and more fetal abnormalities in the first trimester. And in a recent publication involving more than 100,000 pregnancies, we demonstrated that for many major fetal defects, the first trimester scan can be useful in identifying this. But we also learned something interesting, and that is the bracket at which we were originally doing the nuchal translucency was 10 weeks to 13 weeks and 6 days. However, at the time, we were also learning that if you did CVS, chorionic villus sampling, during the 10th week, there was increased risk of limb defects. And therefore, it became an agreement that we will only do chorionic villus sampling after 11 weeks. And at that time, I said, well, there's no point in doing screening at 10 weeks if we were not going to investigate further until 11 weeks. So I moved things along to the 11 to 13 weeks and 6 days scan. As the expectation that this assessment was not just for the measurement of nuchal translucency, as is the expectation in England, unfortunately, but people that have self-pride could also begin to look for other things. It became obvious that the 11 to 13 week scan is a major first fetal anomaly scan. It also became obvious that it is much better, it's much easier to visualize the fetus and the fetal anatomy during the 13th week rather than during the 11th week. And therefore, in our unit, for example, we very rarely see women at 11 weeks because you can't see very well. So we book them for the first trimester combined test towards the end of the 12th week and the beginning of the 13th week. And this is defining the next steps that I will be discussing. In a study involving 71,266 pregnancies in the first trimester, including 263 that had trisomy 21, we looked specifically at the relationship of PABA and PLGF with Downs. The black interrupted horizontal line, this one, represents one mom, multiple of the median, which is the normal range. In pregnancies with Downs, PLGF, the red lines, is reduced, and it is uniformly reduced from the 11th and the 12th and the 13th week. The deviation from normal in PLGF remains constant throughout this gestation. In the case of PABA, something different happens. The earlier we go, the greater the deviation, and therefore the greater the performance of screening for PABA. But as we approach the 13th week, then PABA becomes less important. Follow me through. The consequences of this finding are very simple, really. If we look at combined screening, maternal age, nuchal translucency, free beta HCG, and PABA, at the 11th week, the detection rate is 94%, whereas if we use PLGF, it's 90%. When you go to the 12th week, 90 for PABA, 87 for PLGF, and we now go to the 13th week, and we are beginning to see this reversal that PLGF is beginning to become better than PABA. Now, somebody could argue that if now the objectives of the first trimester assessment is both to identify as many chromosomal abnormalities as possible, but also to identify as many fetal defects as possible, well, the ideal scenario is to take a blood sample at 10 weeks and then do an ultrasound scan during the 13th week. Well, that is one approach, but I think that it is cumbersome, it's unrealistic, it is not cost effective, and I think that most people do the assessments together. Certainly in our unit, people come, we take a blood sample, we do a scan, and by the time we finish the scan, we have the results of the blood sample, and we give them a combined result. If that was the case, and we are therefore now in our unit, where on average, the screening was carried out at 12.7 weeks, then either PABA or PLGF are equally good. And then we looked at whether, do you need to do both? And the answer is that there is no additive effect if you do both. So this is the conclusion about screening for Downs. Now, does it matter that the performance of screening becomes less and less with advancing gestation? Not really, because 20 years ago, we wanted to keep the screen positive rate at 5%, as low as possible, 5% false positive rate. But now that the investigation of the screen positive is not chorionic villus sampling, but in many cases, unless the nuchal translucency is more than 3.5, in the rest of the cases, we can investigate a screen positive result by doing cell-free DNA testing, which is non-invasive. Then perhaps we can afford to have a screen positive rate, a false positive rate of 10%. Why not? Because that way, we do a scan at the end of the 12th week, the 13th week, we maximize the detection of fetal abnormalities, we tolerate a screen positive rate of 10%, and then we offer cell-free DNA testing to this population. And the cell-free DNA test is becoming increasingly cheaper. And this way, we maximize the detection of defects and also chromosomal abnormalities. In that ideology, you can either use PABA or PLGF, but I think it is better to do PLGF for the next step. Let us now discuss screening for preeclampsia. I just want to divert a little bit to summarize how it has taken also 30 years to produce one slide. Today, I'm showing slides that take 30 years to make. This slide summarizes all of the useful biomarkers that we described in the last 30 years. We have looked for many, many others, but these are the only 6 useful ones. Mean arterial pressure is useful in the first, second, and third trimester. Uterine artery Doppler is useful in the first, second, and early third trimester. It is not useful in the late third trimester because in late preeclampsia, uterine artery pulsatility index is normal. Placental growth factor is useful throughout pregnancy. PABA is only useful in the first trimester, and that is only if you do not have PLGF. FLIT goes up about 5 weeks before the clinical onset of preeclampsia, and therefore it is not useful in the first trimester. And the most recent marker that we have described and we are doing extensive research on is ophthalmic artery. And because many of the audience are people involved in ultrasound, I just want to tell them the very latest results in this field. Now, this is the eye, and the ophthalmic artery is the first branch of the internal carotid artery. So, and it runs around the optic nerve. So originally people were saying it's an indirect vessel to examine if you want to examine the brain because of the association with the internal carotid artery. It is very easy to do. You do an ultrasound scan, you finish your scan, the woman is lying down, you take a linear transducer with the same machine that you have used for your scan, you put a bit of gel and you place it gently over the closed upper eyelid of the woman. It is the most simple ultrasound examination that you have ever done in your life. Because even if you're blind, when you place the transducer on the eye, there's only one thing that you see, a big black ball. That is called the orbit. It cannot be anything else. There are no bones there. There are no strange shapes. It's the ball. It's the eye. And then you press the button. There it is. Nothing else. You press the button which says color Doppler on. There's only one vessel that you see, and that is the ophthalmic artery. And then you just put the transducer on and you get a waveform. And this waveform is very, very interesting. You have never seen it before. You didn't see it in the umbilical artery, you didn't see it in the middle cerebral artery, you didn't see it in the uterine artery. It's weird. It has 2 systolic waves and then a diastole. Why 2 systolic waves? People in the beginning were thinking that this is early diastolic wave. No, it's a systolic wave. When our heart contracts, blood is pushed into the aorta and then up to the brain, and that gives you the first systolic wave. The wave of blood then goes to the periphery, where it hits small arterioles, and it is reflected back up the aorta and then backwards into the brain, and then you get the second wave. So the first wave is a marker of cardiac output, and the second wave is a marker of peripheral resistance. To normalize the results, you divide the one by the other. You divide the peak systolic velocity 2 by the peak systolic velocity 1. And you have now, in a series of mega studies, screening studies, in the third, in the second, and now in the first trimester, showed the blue line is normal, the red dots and the red lines are from pregnancies that many months later or weeks later developed preeclampsia. So this is a new addition in our process of screening for preeclampsia, first, second, and third trimester. Let me now go back to address the question of PABA versus PLGF for preeclampsia. We have the combined test, where we combine again history, uterine artery Doppler, mean arterial pressure, and PLGF to identify during the 12th week of pregnancy about 90% of women that will develop preeclampsia before 32 weeks, 75 before 37 weeks, and only 45 at term. So we have a good method developed over a number of 20 years of identifying a high-risk group for preterm preeclampsia at 12 weeks. And then what? Well, then we had the ASPER trial, where we took these women identified as being at high risk, we randomized them into aspirin, 150 milligrams every day from 12 to 36 weeks against placebo, and we showed that you reduce the rate of early preeclampsia before 32 weeks by about 90%, preterm preeclampsia by about 60%, with no impact on term preeclampsia. Magdalena Lewinska will be discussing how do we go about identifying late preeclampsia later on. Now, the question now, in screening for preeclampsia, is PLGF better or PABA? Because if you're doing screening for Downs in any case, and you're using PABA, why spend more money in measuring PLGF? And there are some people that believe that this must be the argument. Well, this is the reason why we need to measure PLGF. We did a study involving 60,800 patients in the first trimester, and we're trying to predict preterm preeclampsia. And these are, for those of you that understand statistics, it's called the McNemas test, where you compare two policies. Screening by history versus screening by history plus PABA. You improve the detection from 45 to 48.6, but that's not significant. Whereas in screening for preeclampsia by history plus PLGF, you go up from 45 to 60%, which is highly significant. If you use history PLGF, do you gain anything by measuring PABA? Answer, no. Then we look at the complete combined test. If we use history plus MAP plus uterine artery PI, do we gain anything by adding PABA? No, we lose nothing much, 66.8 versus 67, not significant. What about if we have history, MAP, UTPI against history, MAP, UTPI plus PLGF? Yes, we do gain something. Additive? No. So here we are. We now look in two specific studies involving 25,000 pregnancies where there was prospective non-intervention screening. It means that we screened We didn't reveal the results. We did not act on this. And then we looked at the additive effect of PAVE. Thus, PAVE improved the prediction of early preeclampsia over and above maternal risk factors. Yes, it does a bit, about 5%. Does it do so when we add MAP? It sort of looks like it, but the blue line crosses the black line, so this is a not significant improvement. If anything, maybe 4 to 5%. Let's say, once you measure uterine artery PI, PAVE doesn't actually improve things, and certainly when you do maternal risk factors, mean arterial pressure, and uterine, PAVE doesn't do anything. It doesn't improve at all the prediction of early preeclampsia. What about PLGF? PLGF improves the prediction provided by maternal factors and blood pressure by 15 to 20%. It improves the prediction provided by the addition of uterine active PI by about 10%, and between 5 and 10% in the complete test. So what are the conclusions? That in screening for preterm preeclampsia, the target for treatment with aspirin, it is by far better to do PLGF than PAVE. And this is summarized on the right. Is the detection rate at 10% screen positive rate, maternal factors alone 45, PAVE a bit of an increase, big increase PLGF, MAP, UTPI, and both, i.e. MAP plus UTPI plus history, we go from 75 to about 81%. So I can conclude that in screening for preeclampsia, there is no question about it. We need to measure PLGF. It's just not good enough to rely on the PAVE that we get for down screening. In the case of screening for downs, we can get better results if we are screening at 11 and the 12th week using PAVE, a bit better if you are using PLGF. And if you have a combined clinic where you do the blood sample and the scan at the same time, and your objective of the clinic, in addition to screening for chromosomal abnormalities, is to look for fetal defects, it's best to do the scan later on when the performance of screening by PLGF and PAVE is the same. And therefore, somebody could argue, why not use PLGF for both screening for Downs and preeclampsia? And that is what I think we should be doing. We have this and many other discussions in Crete at the end of June, and I hope that I will see some of our friends there. Thank you, Mirek.
Thank you very much, Kypros. It was, as always, very impressive, and it's always a pleasure to listen to you. I'm very impressed about this ophthalmic artery, which seems to be a very good diagnostic tool because it's very simple examination. I will try, of course, to do it, and if I have any troubles, I can ask my wife, who is ophthalmologist, to help me.
Don't, because she may tell you it's dangerous.
Yeah, I think it's not dangerous.
No.
One very practical question about the PLGF in our first trimester diagnostics. So your recommendation for replacing the PAVE is from the 13th week of pregnancy?
Yeah, so if really, I think the ideal for me is that we should be measuring in the first trimester both PAVE and PLGF for the two major evolving new indications, in the same way that we should be doing an anomaly scan, not just measuring the nucleus.
Yes.
If we don't have money and the government says, no, you cannot use both, you have to choose one, I would choose PLGF, because PLGF is as good as Pavey during the end of the 12th, 13th week, but Pavey is not good in screening for preeclampsia.
Professor, I have a question. Could I?
Yeah, of course, Sebastian, do it.
Good morning, Professor Nicolaides.
Hi, Sebastian. Hi.
So I have a question. If you have the unlimited amount of the money, so
Yes.
definitely. But if you in this way, could you suggest the NIPT plus PLGF in this moment would be the best screening for the both sides?
Yes.
Thank you very much.
But Sebastian, listen, you know very well that we must not fall into the mistake of becoming victims of the companies and we become salesmen for them. And we lose this major gain that we had in the last 30 years of doing a first trimester scan. So the question that you asked is, should we be doing a very good anomaly scan at the end of the second, beginning of the third trimester? Yes, forever, number one. Number two, should we be measuring PLGF and uterine and then MAP for screening for preeclampsia and growth restriction and stillbirth? Definitely yes. Can we afford to drop free-beta HCG and Pavey and replace that with cell-free DNA? I think that that will happen relatively soon, sooner than people think, because the price of cell-free DNA testing is coming down, and therefore very soon it will not make any sense to do screening and then another second screening. So I agree with you. Yeah.
Thank you very much. And I can see Professor Sieroszewski wants to ask the question.
Yes. Yes. Good morning.
Hi, Piotr.
Good morning, Professor. Hi. My question is simple. I'm very impressed with this ophthalmic artery Doppler. Do you think that we would incorporate this method into the screening of preeclampsia?
I think so. And Piotr, there is a paper that we have just written on even during the third trimester. You will have talks about that later on, about the value of PLGF in the triage system. We have done a head-on comparison in the third trimester when women come in and you don't quite know whether they will develop preeclampsia or not. And it looks to be at least as good as the FLIT to PLGF ratio. So I think that it will be something that we will have available to us to quickly make decisions. But I mean, these are preliminary results on that element, but I want to see more publications. So if you want to do research, this is an area of evolving research.
But Kypros, do you think it's a single marker of preeclampsia or it should be a part of the algorithm?
Absolutely. Of course, Mirek, yeah. All of these biomarkers on their own, they are okay, but actually you need to take into account the background of the patient, both in the first and the second and the third trimester. So in our publications, look them up on ophthalmic artery. They have come out in the last couple of years. It has an additive value on whatever the method of screening is in the first and the second and the third trimester, not on its own. I don't think that it's always nice to believe in obstetrics. We like to have simple messages, yes, no, but life is not quite like that. I think we have an additive value. History is always important. Uterine artery Doppler, blood pressure is important. PLGF and ophthalmic artery has an additive effect. Yeah.
Okay, thank you very much. And I have a question from the audience. From Lotta Ulfstedt. Professor Nicolaides, how can you time the visit to week 13 if ultrasound is not done yet and it's based on last menstrual period?
Yes, I can see your point, but when women get it wrong, and you're right, in about 20 to 30% of the cases, they may get it wrong. They have irregular periods, they have delayed ovulations and so on. The good news is that they get it wrong by overestimation. it is quite unlikely that the woman, we give her an appointment at 13 weeks and you realize that she's now 14 or 15. At most, when you give her an appointment at 13 weeks, she will be 12 or 11. Yeah. Many years ago, when I was not part of the system, I was advocating that all women should have a scan at around 7 weeks so that you can exclude an ectopic pregnancy and you can show the mother and the father the joy that there is a heart beating there, and that if the baby is alive at 6 to 7 weeks, the risk of subsequent miscarriage is about 4%, not 20% or 4%. So I believe that you should be doing a scan and the dating at 6 to 7 weeks, and have a scan for anomalies and screening at around 12 to 13 weeks, 20 weeks for the mid-trimester scan, and I can see Magdalena getting ready to speak about second trimester screening, and then a 36-week scan. I was doing a 32-week scan, and now I moved to 36. If it was up to me, every obstetrician in every clinical visit should be doing an ultrasound scan. But this is the scans that I think should be the minimum. In England, we only are allowed 2 scans, 12 and 20 weeks, full stop. So, yeah, this is the answer, really. I agree with Lothar that sometimes you will get it wrong, but the good news is that if we get it wrong, the woman will be less pregnant than we think rather than more pregnant. Yeah.
Thank you. Professor Borowski, yes, please.
Yes, I have one question. In Poland, we have still the problem with the PLGF not currently included to the package of service guaranteed by the NHS. What do you think, dear professor, about the 0.4 months for the pay to estimate the risk of the preeclampsia? I know it is not good scam, but you know, in this moment in Poland is the big problem.
I think that Poland is impressively advanced. I remember when my friends, a lot of the leadership, Mirek was a little baby at that time, they came to Cyprus to blackmail me to go to Poland, and I hate flying. So they forced me to get into this horrible airplane from Stansted to arrive in Katowice. And it was a very, very bad weather. And when we landed, the pilot said, now they stopped the flying. And that was the first time I arrived, and the people were really...
It's from Katowice.
And, you know, every year since that time, I have been seeing an enormous progress. And in many, many respects, your national system, surprisingly, has introduced screening, which is better than what we have in England. So that's to put things in perspective. In England, I'm fighting a battle for PLGF, and I'm not winning. In England, they're doing what you have just said. They're using PAB-A less than 0.4 moms as a method of identifying a high-risk group that will have, in addition to the routine 20-week scan, a scan at 28 and 32 weeks as a marker of fetal growth restriction. I think that is better than nothing, but they're so very primitive, really, these approaches. Yes, no. I mean, if you're going to screen for smallness, you need to take into account the history, age, weight, race, method of conception, previous obstetric history, and then combine it with biomarkers, uterine artery, plus PAB-A, if you're going to screen for smallness. What shall I say? If we have nothing else, Darius, well, that's better than nothing. But I think I'm very optimistic that in Poland, you will be able to be introducing PLGF.
Yeah.
You have a government, whether you like it or not, that is very much investing into the concept of the family. So I think that you have a good target to campaign.
Okay, thank you very much.
Good to see you.
And Dr. Litvinska is raising her hand. Magda.
Hello, Prof.
Hello, Marta.
I wanted just to ask you, do you think that this ophthalmic artery Doppler could be also useful in screening for preeclampsia in twins?
I know why you're asking me this question, and it's irritating because you're doing that, isn't it?
Yes.
Can you answer the question yourself?
It's auto-promotion.
Yeah.
But be careful, be careful, because I am doing that. And now, if you're competing with me, we will see who is faster.
Okay.
So if you want to beat me, you better work harder.
Evelina is scanning now the twins, so I think she did at least 2 today. So
okay. I think there is no reason. It's interesting though, be careful, because if we take twins, the risk of preterm preeclampsia is 9 times higher than in single. This is a very, very good group to investigate scientifically, because you will have a good yield. So that's the first point. But what is it that the ophthalmic artery is looking at? Is looking at peripheral vascular resistance. It is very interesting to find out whether it will be useful in twins, because the other twin, one of the twins may have the placental insufficiency that triggers off the preeclampsia, and the other twin may be all right, in the same way that 7-trimester serum biochemistry, for example, is not reliable in twins because the normal placenta overwhelms the abnormal placental function. I don't really know how the peripheral resistance would be, whether the one normal twin will be reducing the peripheral resistance and masking the increase from the other. Let's find out. I will give you another 3 to 4 months. Otherwise, I will publish something. Okay.
Okay. Thank you. Thank you, Prof.
Okay.
Okay. Thank you very much.